I would say that from the perspective of the way that the care coordination payments were structured for the state programs, they were structured initially to recognize the patients who required the most coordination of care and add additional payments for circumstances where the patient had a major mental illness or where the patient or their caregiver did not speak English. There are some things that we need to look at in terms of the tiering method that we use to allocate the tiers. One of the other criticisms that's often raised is that we, in the state programs anyway, we didn't make any payment for patients who did not have a major diagnostic condition. The reason for that was actually purely budgetary. The method for allocating payments was set up in a way that you could make a payment for people that did not have a primary major diagnosis. It would be pretty small per member per month, but you could still do it if you had the financial resources to do that. The other thing that we need to do is to look at the method of certification and recertification. So in the recommendations from the Governor's Task Force, one of the strategic elements of the first recommendation that we made, or the first strategy, is actually to go back and look at the certification method and the payment structure to see what improvements can be made in that method. Minnesota is a little unusual in terms of how we decided to structure the payment for coordination of care. Again, where we created structures for higher payments for more complex patients rather than using a flat across the board per member per month payment. Again, the rationale for that was that 5% of our patients account for 50% of the population's costs. When we actually in the Center for Innovation have looked at how physicians are spending their time, doing some experiments in a primary care practice in Casson, physicians actually spend a lot of time doing things they shouldn't. In fact, when you ask patients what they need and why they have come, only about 5% of the physician visits in this practice anyway required a physician. About 10% of the visits didn't require even being in the clinic, and the rest could have been handled by someone other than a physician. Unfortunately, the only way you can get paid in most circumstances is fee-for-service for the physician. So this is why you have to do practice reform and payment reform and benefit change all at the same time. You can't do them one after the other. The last consideration, of course, is what is the payment level in reference to the question earlier about where is primary care recognized in Washington? We have to try to make sure that we avoid the problem of cost shifting and not paying a reasonable amount of money for the same service. It doesn't cost Mayo Clinic any less to take care of a patient with Medicaid than it does a patient with Blue Cross Blue Shield insurance, but we're going to get paid a lot less. It's the same for you. So somewhere we need to find a way that we can address the problem of that lower reimbursement level at in a government program. Now, the challenge for us as providers is that if you look at spending, most experts agree that about a third of the spending that we have now is wasted. And most of that is clinical waste. I mean, there's some administrative waste, but there's a lot of clinical waste, missed preventive opportunities, duplication of effort, and things like that. So what we're hoping is that if you can take some of that money from clinical waste, you could turn that back into payment for coordination of care. I mean, that's where we have to try to redistribute the funds. It's a challenge to do that, but if we thought about how we could do that, a more aggressive effort and a consistent adoption by payers across the board might help that.
The next, excuse me, the next question is, how will the business community create change in healthcare that will start to value primary care, leading to lower cost and more effective utilization?
I would submit that actually, in some respects, some of the business community had been leaders in that area recognizing the value around both from a productivity, but from a cost standpoint, the wellness and health of their population. So the interesting thing about being in Minnesota is that a number of our employers here are engaged in wellness initiatives around payment reform, around coordination of care, which is why when Doug made a comment obliquely about public-private partnership, I would almost say that's kind of the mantra about health reform in Minnesota. We do things together here. It's not a function of government. It's not a function of the private sector. It tends to be actually a combination of both entities working collaboratively to come up with solutions. So the business community has a stake in this game, and at least in Minnesota, a number of them are stepping up.
Can I add something?
Yes, go ahead, Ann.
And I would just add, not so much related to business community and primary care, but the business community and healthcare in general. There's a lot to be gained from a business perspective in single payer. The Lewin study that was released in March actually showed that for employers in Minnesota who currently do offer health insurance to their employees, the average employer would save $1,200 per employee per year by paying into the single payer system rather than by buying private insurance for their employees. And so obviously employers who currently don't provide insurance would pay more because everyone would pay into the system, but those employers who are currently providing insurance would realize significant cost savings. And so from a business perspective, if you're a small business owner really struggling to provide coverage for your employees, single payer gives you a nice advantage.
There's, on businesses, there's two more questions, so we'll stay on that topic for a moment. Business provides a product to consumers. Health can be holistic wellness, but is often seen as the absence of disease. How can we trust that businesses will hold up true wellness? How can it be trusted to sell the absence of something?
Well, I think that from the perspective of most employers, we really look at this as a quadruple aim, not the triple aim. And the military defines the quadruple aim as the triple aim, better cost, better service, lower cost, better health. And then they define readiness as the fourth aim. And the business community would define that as presenteeism, absenteeism, productivity as the fourth element of that. Actually, productivity is pretty well defined as 60% of the total cost of healthcare to us. It isn't the expense of the procedures, although that's become god-awful. It's the lack of a productive workforce that's more effective than that. So, I think many of us have gotten that now, although there tend to be leaders in industry, just like there is in anywhere else, and there tend to be people who don't get things, and there tend to be followers. So, we're looking at value-based benefit design. We're looking at incenting wellness programs in that benefit design. I think there's a lot of leadership around that as well. It's a journey that we're all on, but I just read a study that came out in pediatrics in the last week or so, looking at comparing medical homes versus non-medical homes for asthmatics. And it turns out that in this particular study, I don't remember the numbers exactly, but I think there was like 4.3 days of school lost more in a non-medical home, a non-really managed asthmatic environment than in the managed environment. But that directly resulted in 3.2 days of lost work for family members taking care of those kids. And those are something I think we pay attention to. I know that Mayo does it as an employer. I know that probably the state is beginning to do that as an employer. So I think that it's obviously in our interest to do that, and but you're right. In the sense of when we think of healthcare, we're really talking about sick care, and that's why I think it was so cool that in Vermont they took 1.9 cents out of every sick care dollar, and they used that to create a community coordinator that community coordinator pulls together the entire community, and they identify the 3 things that community is going to look at in terms of wellness and health. And then that community coordinator pulls every single agency, not-for-profit agency, et cetera, together around a table once a month, and they decide as a community, are they going to build a hiking trail for the diabetics, da-da-da. I mean, those kinds of things are things that communities should be doing. It's the kinds of things that they're looking at doing in Dodge and other places. I contend that in order to have a healthy workforce, you've got to have a healthy community. I mean, when we began looking at this whole concept of medical home, one of the things we looked at very seriously at IBM was building it ourselves, right? I call it corporate concierge medical home. It's a model that's well established, well used. You know, if you can't get medical home level care, if you can't get that kind of care you want to get, build it on site, near site. Only have your employees do that. We elected not to do that, and we elected not to do that for a reason. And the reason was that fragments care in our community. It doesn't allow you as a provider to take care of me and my retired mother, right? I mean that doesn't provide a healthy community. And at the end of the day, it's all of us working together that create health. I mean, there's a huge sense of who you hang out with, if they're thin or fat, if they're healthy or not healthy, begin to impact all of us, right? So, I mean, that's gotta be something that we address together.
So in the work that we've done in Dodge County, we look at it in a similar way, and that is the economic vitality of the community depends on the ability to create health in the community. The employers in Dodge County, which include some schools as well as a truck manufacturer and then agribusiness, as well as the Mayo Clinic, can't attract and retain a good workforce unless you have good health. You can't have good health unless you have good education. You can't make the necessary investments in education if you're wasting the money on unnecessary health care that doesn't actually produce health. We actually are looking at how the practice fully integrates social services or community services in the practice. What that means actually is that in the clinic, if one of the people that we saw looked like they needed some help with heat or with food or some other assistance, that we actually have a community health worker or a non-licensed person who will get that. The physician, in essence, writes an order or a prescription and says food, heat, medicine, whatever. We also have in that community engaged the schools in figuring out how do we actually take advantage of resources in the school, or how do we move clinic resources into the school. And there are a number of ways you do that. It can be with people. More importantly, you can think about how you take advantage of communication. You have a web-based care plan that you share, and the data goes back and forth. You have an ability for the delivery system to interact either in person or electronically with a nurse, a teacher, some other provider at school, where we can take care of a problem when it really develops and avoid a trip to the emergency room, or as some of the residents of Casson say, downtown, which to them means Rochester, 20 miles away. So the delivery system has lots of opportunity. We just need to step back and think about how we design it that would meet the specific needs of individuals. We've also tried to get across to the community the choices that they make every day at work, at home, in the grocery store, not going to the gym, not taking their medicines, not filling a prescription. Those are all choices that have an impact on every person in the community, because in essence, all of us are going to cover the healthcare costs of the entire community. And then when you look at it from the perspective of individual budgets and show the impact on a family's budget, it can become significant. And then when you're thinking about, well, okay, well, how can I build a bike trail? Well, in a population of 20,000 in Dodge County, if you could save as little as a couple $100 per person over what our current spending is, you generate about $28 million in savings that you could use in other things. So that's a lot of stuff.
Thank you. We've got about 5 questions left, and we only have about 8 minutes. So